Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Dave, and we are going to talk about all things inflammatory response and steroids. How are you doing today, Dave?
I'm doing great, Dennis. Hello to you and your audience. Thanks for having me back.
Well, since you were just on a very recent podcast, we won't need to go through the normal introduction, but just thinking about it, everybody knows you're a neurointensive care specialist, but it also turns out that you are a doctor and you know more than just neurology.
Well, I hope so. That's certainly what we'd like to tell people. I guess we'll find out today when we're talking about our topic.
So, diving right in, what I'd like to know is, when is the right time to use a corticosteroid? So, recently the recovery trial came out, and they're talking about using corticosteroids, dexamethasone specifically for COVID-19, and they're seeing some good things. But usually when I hear about steroid use with other pathologies like ARDS and sepsis and spinal trauma and et cetera, it never seems to work out. So if you could explain some of the background stuff on the inflammatory process, I think that'd be an amazing place to start.
Yeah, sure. We can start by going over inflammation in the body's inflammatory response to injury. So when you brought this up to me, it actually it reminded me of a quote that I had found once in an old textbook, and I went and I dug that out, and and I think it really will set the stage for what we're going to talk about and the complexity that is the inflammatory response and the treatment of that. And it came from a Scottish physician from the 18th century named John Hunter. And Hunter was actually known primarily, perhaps unfortunately, most for injecting himself with one of his patients' fluid discharges, and ended up giving himself syphilis and gonorrhea. But he was actually a pretty observant individual as well. And in this textbook, what they had quoted him as saying was that inflammation is not itself considered a disease, but a salutary operation. But when it cannot accomplish the salutary purpose, it does mischief. So, and I think that really kind of sets the stage for what we're talking about when we talk about inflammation, because the inflammatory response is in a broad sense, the complex process that is triggered by the body when it undergoes some type of physical injury or microbial invasion. And it's important to remember, I think, that the purpose of inflammation or the inflammatory response is to generate noxious substances that are designed to control and eliminate threats without hurting the host itself or the host cells. The problem is that when you get a sustained or overwhelming inflammatory response, it sort of feeds into itself and creates this sort of self-sustaining loop where the inflammatory response is calling in additional cells, and these cells produce more markers that enhance or further inflammation, and it kind of perpetuates from there and creates injury. And this is a process that's sometimes called malignant inflammation and can lead to multi-organ dysfunction and multi-organ failure and ultimately death in certain situations. And of course, it's more prevalent in certain body systems. The lungs, the brain, the kidneys, for example, are some that are particularly injured by that malignant inflammatory response. But it is something, again, that is designed to do good and to help you. For example, you get these oxygen metabolites as the body is responding to some type of injury, and one of them, for example, that it creates is something called hypochlorite, which is actually a very, very powerful germicidal, and it's included in bleach. But too much of anything is a bad thing. So in general, what happens is there's a number of cells that are activated when you have some type of inflammatory injury or injury causing an inflammatory response. And before I kind of go into that, we'll just sort of briefly mention that there's really two types of immunity in the body. And the first one is called the body's innate immune response, or that's the type of basically the type of immunity that you are born with, that you have inherently. And this is a non-specific type of immunity that is basically already primed to respond to some type of injury. And innate immunity consists of things like barriers, so skin, for example. We know that intact skin does pretty well keeping dangerous microorganisms out. Mucous membranes or tears are other examples of that. You have chemical barriers. Actually, tears would fall into that. I apologize. Or the stomach's acids. Those would be examples of chemical barriers. And then you have certain types of cells like neutrophils, eosinophils, mast cells, dendritic cells that are kind of circulating and again are non-specific and are sort of ready to respond to a threat and begin to contain that threat before shifting over to what's called adaptive immunity, or that's the acquired immunity, and that's your sort of second line of defense, so to speak. And that's where the body develops a particular response to a certain threat or a certain type of antigen microorganism, be what it will. And this typically consists of things like B cells, which encounter a foreign object, a novel antigen, and they create the specific antibodies that our body then remembers and holds on to later on, in most cases at least, to destroy it if it's encountered again. And then it has T cells as well, and there's different types of T cells that will help do the same thing, that help address things like viruses like SARS-CoV-2. Again, this is the type of immunity that you hold on to for extended periods of time, so that if you encounter that organism again in the future, your body's already primed to recognize it and defend against it. But when you're talking about the immune response, the first thing that happens in most cases is what's called neutrophil activation. So this is a very, very early occurrence. So you get an infection. When we've been talking about SARS-CoV-2, so we'll kind of use that as our example. But it tends to lead to a 20 to 50-fold increase in oxygen when you get neutrophil activation. And the consumption of that oxygen, or oxygen consumption rather, is what's increased. That leads to a process called respiratory burst. And it sounds like that has to do with oxygen, but it actually doesn't. It's a process that generates toxic metabolites from the metabolism or the breakdown of all that oxygen that's now being consumed as a result of the neutrophil activation. So this creates a number of products. I mentioned one earlier, the hypochlorite. You get superoxide radicals, hydrogen peroxide. You get other types of hydroxyl radicals as well. And these oxygen metabolites function essentially to disrupt cell membranes. They can break DNA. They can denature proteins. And they're meant to do devastating damage to microorganisms. And the host cells, in turn, are protected from these oxygen metabolites doing damage to them by various types of antioxidants. But when the oxidants overwhelm the antioxidants, the host cells end up getting damaged. And that's where some of this problem comes in, and where the inflammatory response can do damage. And you get these chain reactions where I mentioned superoxide radicals, for example, and hydroxy radicals are actually missing electrons in their outer orbits. And what they do is they pair with non-radicals. So they take some of the electrons from the non-radicals, and that changes these non-radicals into free radicals. And these are damaging, and you get stuck in this sort of process that I mentioned before, where you're creating more and more of those as a result of the inflammatory process, and that leads to injury. So this is some of the that's kind of an overview or a brief explanation of what's going on, and sometimes the body tends to overamp itself or overreact, and you get kicked into that inflammatory response that just does more and more damage, maybe even more so than the original organism, the original threat that we're talking about was doing itself. and that can be very dangerous and can result in serious illness or death.
So this inflammatory process, as it naturally kicks off, I guess how fast can this really spin out of control? Are we talking a couple hours, or is this over days?
Yeah, most of the time, at least in terms of if we're going to talk about SARS-CoV-2 in terms of infection, it's usually a problem that occurs much later. So, for example, with the SARS infection or the SARS-CoV-2, one of the things that was noticed, I think, early on in some primate models was actually that the virus itself would kind of start to subside itself, or the replication of the virus, the effects of the virus would start to subside itself. And it wasn't until I think it was about 10 to 14 days or so in that they actually started to develop that inflammatory response after, again, the virus had started to subside. And this sort of mirrors what has been reported with SARS-CoV-2 patients, in that usually it's within the first 5 days or so, patients start to develop symptoms. But it's really more around day 8 to 12 where they start to get really, really sick, and that's where they seem to be at their highest risk. And I think where that's occurring is a lot of times that transition period from innate immunity to active or adaptive immunity, and where things can go wrong and where the immune system can overact. So obviously outside of infection, outside of the viral infections, things can happen at different paces. Certainly, depending on the type of underlying imagery, you can certainly develop an inflammatory response much faster with certain types of traumatic injuries, for example. But at least in terms of infection, you usually got a little bit of time before all that develops and becomes pretty serious.
Okay. So you mentioned with trauma it can happen pretty rapidly. Are we still talking, 4 days, 3 days, 4 days, 5 days, or can it happen much faster?
Well, like you mentioned, I tend to default to neurology and neurocritical care because that's my primary background. But in terms of TBI, for example, or spinal cord injury, you can start getting bad swelling and herniation and such as early as 30 minutes after a traumatic injury involving that particular organ system. Part of that has to do with the fact that it's in an enclosed, rigid space that some of the other major organs are not in. But certainly it's something that can happen very, very quickly in trauma situations, as I just gave an example of.
Okay. So, the use of corticosteroids, it definitely, at least outwardly, it seems like a reasonable idea. Really, at any time, you have inflammation that is causing more problems than it's actually helping. So I'm going to shut the system down. How does a corticosteroid, exactly does it shut it down, and what are the consequences of it doing that?
Yeah. Okay. Let's talk a little bit about steroids and how they work. And the answer is quite complex. So I'll try to stay broad, or at least provide a broad overview of this. But you're right. There is when we think about inflammation, we think about reducing it, and steroids is a very potent agent that allows us to do that in some cases. And if you look back, 30, 40 years ago into the literature, there's actually a lot to support its use in different traumatic situations, in different infectious situations, and you get reports actually of good outcomes. And I'll be honest with you, there are situations even in neurotrauma, for example, and in Crash 1 that came out in it was 2004, 2005 timeframe is really the trial that put a stop to the use of it in TBI, for example. But if you go back before that period of time, you can actually find a lot of literature to support its use, to say that it actually was associated with better outcomes. And I think that most of us that practice in these types of fields can come up with a patient that we tried that on, even after some of these major trials that dissuaded us from continuing to use them, at least on the larger scale. Most of us can come up with a patient or two where it seemed to work very, very well, and there were good outcomes. So I think it's important to remember that although it may not be something that we can apply in a broad sense, that there are probably transition periods or certain patient pathology or even a time frame where it might be more useful to use than not. But we can come back to that and try to define that a little bit better, especially with SARS-CoV-2. But when we talk about steroids, there's different ways to classify them. And in the broader sense, what we're really talking about using for inflammation is what's called glucocorticoids. So glucocorticoids are the type of steroids that have an anti-inflammatory action. They have an immunosuppressive action. They have vasoconstrictive effects. Contrast that with another type, which are called mineralocorticoids, and those are completely different. Those are really not designed for the type of situation that we're talking about. Their role is more in regulating body water balance and regulating electrolytes. So I use those, for example, in when I'm trying to get somebody to retain fluid, and subarachnoid hemorrhage patients, for example, is a big one. That I'll use something like fludrocortisone, which is a pretty potent mineralocorticoid, because it helps that patient retain fluid. It helps raise their salt levels, and that helps, we think, prevent things like vasospasm, for example. But we don't want to use that type of agent in a lot of these trauma situations or a lot of these infection situations, especially in somebody that has ARDS. You generally don't want them retaining fluid or having electrolyte imbalances as a result. So what you're really looking for is you're looking for an agent that has mostly glucocorticoid activity or all glucocorticoid activity and very minimal mineralocorticoid activity. So some other examples of these, for example, just to kind of enlighten the listeners, dexamethasone and betamethasone, for example, are two types of glucocorticoids that don't have any mineralocorticoid activity. And that was one of the reasons that they chose dexamethasone in the recovery trial that you mentioned earlier. Some of the other ones that people know real well would be like methylprednisolone or prednisone. Those have mostly glucocorticoid activity, but they do have a little bit of mineralocorticoid activity. So one of the questions that came up with recovery is, could we use something other than dexamethasone? And you could, but there's a reason that they chose that, and it's what we just talked about here. So, and the question of how do glucocorticoids work? Well, the broad answer is that they modulate gene expression. So they bind to glucocorticoid receptors, or GR receptors, or what they call, and they tend to upregulate anti-inflammatory genes, and they downregulate pro-inflammatory genes. So this will affect a lot of different types of cell lineages that are involved in the inflammatory response, monocytes, eosinophils. And really, GR receptors are present in just about every cell in the body, which is one of the reasons that you get the systemic response that you get from steroid use. Because as many folks know, there are a lot of side effects and systemic effects from these steroids, particularly over long periods of time. But really, they enhance innate immunity. They suppress adaptive immunity, so they kind of prevent that overreaction that we were talking about earlier that can be harmful. They inhibit inflammation really by dampening signal transduction downstream of what are called pattern recognition receptors. And these are kind of a key in order to identify a foreign agent. We're talking about SARS-CoV-2. So it prevents some of that later cytokine response and chemokine response that then sort of feeds into that vicious cycle of an inflammatory response, and then that inflammatory response inducing or calling in more inflammatory cells that then create an even larger inflammatory response. So they do things like inhibit lymphocyte activation. They promote lymphocyte apoptosis in some cases as well. If you've got cells that need to undergo a sort of cell shutdown or cell suicide. So they have a lot of different roles and a lot of different complex ways in which they affect the immune system. But that's sort of a broad stroke overview of how it works.
Right. Now, nothing in life is free, I guess. Whenever I've heard of, using corticosteroids, like, yep, you're going to help reduce the inflammatory process, but you're also going to kind of stop the immune response as well. And, infection is going to take over and they're going to just rot in front of you. I mean, is that really the downside? Is that you shut down the immune response and infection then takes over?
Yeah, in theory. I'll share with you kind of real briefly one of my first experiences with this whole process, and how difficult it was. And it's infection related. It's not SARS-CoV-2, but back when I was a resident in Washington State, I actually had the first case in that state, myself and my attending, of a JC virus infection, which is normally a pretty weak virus that a lot of people are exposed to, but it doesn't affect you unless you end up with some type of immunocompromised condition. So in the patient that I'm thinking of, it was an MS patient who was on a drug that was designed to suppress the immune system, and it's a fairly rare condition, but this patient ended up with it. We found it via CSF sampling and PCR laboratory testing. So the first step was to remove the drug so that the immune system could come back online. It was no longer suppressed. So we did that through plasma exchange. And what we found was that when we did that, especially when we did it quickly, the immune system rebounded, and it rebounded very quickly and very powerfully. In a condition that at least associated with this particular scenario is called IRIS, or immune reconstitution inflammatory syndrome. So now we've got an immune system that has been shut down and suddenly turned back on, and it wants to fight. It recognizes the virus, the JC virus, and it wants to get rid of it. The problem was that ended up doing more damage to this woman's brain than the virus had done originally. So now we were stuck in a position where we needed to resuppress the immune system. So we were looking at steroids, and we were very cautious in doing that because as we were taking CSF fluid off through spinal fluid, we were still detecting virus via the PCR test that we were sending. So the worry was that if we had put on prednisone, or methylprednisolone in this case, the IV form, that we would allow that virus essentially to begin replicating again, or to revive itself, so to speak, in the setting of an depressed immune system now with the steroid on board. But what we found was that this patient ultimately died, unfortunately. But what we found was that the inflammatory response from that condition, from that IRIS, was much more harmful than the virus was itself. What we were probably getting in the CSF, honestly, was viral debris. Since those tests tend to be very, very sensitive, even when we're talking about COVID-19 and the PCR test, even after you are no longer shedding the virus or you're no longer transmissible, it's still sensitive enough to pick up viral debris. So you can still come back positive even though you're not contagious, so to speak. But that was the case in this particular patient. And the answer really was steroids. And since then, we've made those adjustments. And it's forget what we think that the virus is doing, because that inflammatory response is just so powerful and so damaging that it really shut down the nervous system in this patient. It can shut down other organ systems too. So going back to your original question, I think that the take-home message in this is that it's a balancing act. You have to be able to recognize in these patients when the immune system is amping up and when it's doing more damage than it is good. Fortunately, that's not too difficult to do, and we've got a lot of data now in the SARS-CoV-2 patients that allow us to determine that. And again, it's usually something that starts to occur a week or more into their infection, so it's not something that happens right away. But oftentimes, you'll start to see rises in the number of the labs that you're monitoring. And some of that is going to be elevated D-dimer, for example, elevated ferritin, an acute phase reactant. Normally, ferritin is less than 200 nanograms, and when you're developing an exaggerated inflammatory response, or what some people sometimes refer to or know as the cytokine storm, that's kind of a popular term that is linked to all this as well. Oftentimes, that ferritin level will get to 500 into the thousands. Liver enzymes increase. CPK, which is a creatine phosphokinase, is a muscle enzyme that can break down. When you start to see these rising in a patient that you've been checking them on a regular basis, that's a pretty good indicator that the immune system is starting to shift into that overactive stage. And this is probably the zone where you're no longer worried about suppressing the immune system and allowing the virus to replicate or get out of hand. But this is probably the point where, hey, I should think about using steroids in the recovery trial with dexamethasone to suppress this immune system before it starts doing more damage than I want it to do.
Is there a way to, without D-dimer and labs like that, is there a way to kind of recognize that this inflammatory process is getting out of hand? Say I have a trauma patient and we were cruising along just fine, and now because that inflammatory process, I'm starting to hear fluid in the lungs, or the patient is starting to swell, or something like that. I know where things are starting to go south, and I think it's because of the inflammatory process.
Yeah, it becomes trickier certainly without that type of advanced monitoring and that laboratory capability. I can tell you that in the recovery trial, one of their criteria was patients that required some type of supplemental oxygen therapy. So in their 6,000 or so patients, they looked at subgroups, and they looked at how dexamethasone affected patients who were ventilated, and then patients who required some type of additional oxygen therapy in order to maintain their oxygen saturation. So I think when you're starting to consider that type of transition, especially in a SARS-CoV-2 patient, I think that worsening respiratory function, that worsening oxygenation, might be a key for you to institute steroid therapy, even if you can't get the labs to back up that suspicion. That transition point there seems to be where it's most effective, at least according to this trial. So I do think for other conditions, it gets a little bit trickier. So I wouldn't just use worsening in some of the other systems that are affected by inflammation, like the brain and the kidneys, and just start steroids, because when you get into the literature for those, it gets a bit trickier. Hopefully, the pulmonary folks that are listening to this don't get too up in arms. We don't use, or at least at the hospitals I've worked at, we don't use steroids all that often in ARDS. But you could, in theory, and if you're going to do it, it's going to be earlier in the course, usually less than 14 days, and it's going to be in your more severe cases as well. PaO2 FiO2 ratios less than 150, for example. There are some trials where that seems to be helpful. So certainly, if you think clinically that your trauma patient is shifting into an ARDS sort of situation, it's reasonable to consider steroid therapy, and that's certainly been done in other cases such as burns, where there are other considerations or other concerns about using steroids, wound healing, and the decreased or increased risk of infection rather. But that would be a situation where you might want to think about something like that if that's all you've got available and they're making that transition. But other cases like TBI, where the literature is much more controversial, spinal cord injury, where it's much more controversial, I would say that the best thing to do in that case would be to get your consultants on the line and talk it out with them and see if they think that steroids is the appropriate thing to do.
Right. That's probably a wise idea, probably for any type of trauma. Things are starting to go south, and you don't want to just come up with ideas to do. You know what I mean? If you're looking at some kind of systemic shutdown of the immune response, it's probably something you might want to talk to somebody about. So I mean, at the end of the day, when is the right time? I guess what is the right patients where I should go ahead and consider giving a corticosteroid?
Yeah, it's a good question. I'll use the recovery trial in the SARS-CoV-2 patient group as sort of the model for this question and the answer. The true answer is that it's going to be sometimes it's going to be tough, and it's going to be different from one person to another. Because remember that it's not just the organism or the type of organism. It's other factors such as host factors like their genetics, their age, comorbidities that they have that may also affect their immune system. Diabetes, for example, obesity, or some of the ones that have been thrown out there for COVID that tend to be associated with worse outcomes. But for the most part, in an austere setting, I think you've got a little bit of time. At least what we know suggests that for that condition, you've got a little bit of time before that develops. And in most cases, hopefully, that's going to be something that happens when they're in an ICU. But if not, I think what you're really looking for in the setting of an infection is, am I over that period of time where, especially with viruses, that virus sort of reached its max in terms of its replication? Is it continuing to propagate and infect cells? Because if it is, then I may not want to do something that's going to suppress the immune system to kind of put up its roadblocks, so to speak, and to stop that process from occurring. Because we talked a little bit earlier about the whole process, but one of the things that your immune system does as well is not just attack the virus itself. It actually identifies the cells that are infected and tries to shut those down too, because the virus puts its material into those cells, replicates there, and then those cells tend to burst and spread more viral material around. So if the body can find those infected cells and shut those down, then it helps stop that process as well. But if you do that too early, at least in theory, and frankly, there's some evidence of this for, like with the NACES trials for spinal cord injury. If you do this, you're increasing the risk of infection, severe pneumonias, for example, and certainly with a respiratory illness, developing a bacterial superinfection or bacterial pneumonia on top of a viral pneumonia can potentially be very, very bad. So I think that early on, it's probably not something that is going to be used early in the course of the infection. It's really going to be paying attention to what's going on with that patient. And then some of those inflammatory markers, like I had mentioned earlier, are those starting to increase? Is the patient getting worse? And have we had enough time for the body to switch from that innate to adaptive immunity? Because it's really that transition period where the inflammatory system and response has a chance to take off. And I think that that's probably where that's going to happen. It's going to be a little bit different, or rather where steroids are going to be most appropriate and where they're going to be most effective. That's going to be a little bit different from one person to another, but I think the things we talked about earlier can be good guides as to when that's starting to occur.
Yeah, I think the keys is definitely talking with telemedicine and trying to work out, is this patient the right candidate for corticosteroid treatment? What are your signs and symptoms? What labs are you able to bring to bear on it? Also, very wise, I guess, selection of which steroid are you going to use? Is it a very specific to glucocorticoids, or is it a kind of a mix of the two? And being prepared to, suffer the wrath if you're picking the wrong one, because you're going to have fluid and electrolyte shifts if you have something with a little more mineral corticoid effects. Is there any other tips and tricks, I guess, you should think about before administering some kind of a steroid?
In terms of, I think part of what you have to answer, part of what you have to figure out is how you're going to administer the steroid. For most critically ill patients, it's going to be an IV route, which is fine because dexamethasone, methylprednisolone are IV formulations. They're cheap, they're easy to find, and readily available for the most part. We'll see if that holds with the recovery trial data coming out and gaining a lot of excitement for dexamethasone in the treatment of SARS-CoV-2. But you're probably going to want to do that. If you can't, though, and you've got a patient that can swallow, as I recall, they did have oral therapy as an option, 6 milligrams of dexamethasone for a 10-day course. So it's not something that must be given IV. I don't think, or at least the data doesn't say that it has to be given that way. I think that you could give oral therapy if you absolutely had to. But I think that the other thing to remember too is that with steroid therapy, especially systemic steroids, we tend to worry about the side effects associated with that, and even in this situation, there were concerns when some of those news releases came out about some of the early findings in the recovery trial, and people begin to think of things like hyperglycemia and immunosuppression. Probably more in the long-term sense, because you're going to get some of that with the steroid, but in this case, that's what we want it to do. And then in terms of adrenal insufficiency, it'd be another one too. Is it going to affect my cortisol level if I give this medication, and is that going to cause me problems like hypotension and such that I then have to potentially or have to deal with? And of course, the answer to that is no, not really, because we actually use that as a replacement for adrenal insufficiency and trauma. And really, that 10-day course that they were talking about giving in the recovery trial, that's not really long enough to cause a lot of the types of problems that we're concerned about. Wound healing, if you're talking about burns, like the adrenal insufficiency, which would really come after the withdrawal of the steroid. But if I have an intact adrenal system and I give steroids, am I going to suppress that and cause problems? Probably not. Not with a short-term course like 10 days. I wouldn't worry too much about something like that. Am I going to cause problems potentially with other organisms like we talked about earlier? I think that depends on the timing and the condition that you're using it in. It's certainly in theory a potential problem, but again, most of what we're talking about is fairly short term. And frankly, if you've got a serious condition developing, like a cytokine storm or an ARDS picture, that may be what you need to do, because that's gonna be a bigger problem for your patient in the short term than some of these other things like adrenal insufficiency that we're talking about. So I wouldn't be too scared to pull the trigger on something like this in a patient where you think that the inflammatory response is overactive and overamped, because it really, the data from the recovery trial, which was a well-designed trial, is suggesting that it saves lives. And in other conditions, it may do the same thing as well. Just talk to your consultants about it in a specific scenario, and if you think that it's something that might be helpful, and see if you can come to an agreement on that.
Yeah, I think people tend to forget that it's not an all or nothing type game. There's definitely other things in the middle, and just getting good advice by people who use this stuff all the time is probably going to be worth it. Are there any other tips that you can think of?
No, the only other one, kind of thinking as we were going through there, we were looking for we were talking about looking for clinical signs and symptoms of someone that may be transitioning into an overactive immune system. And the only other one I would throw in there too, I think, is that there's been some highlighted coagulopathy problems in the SARS-CoV-2 patients, or this kind of disseminated intravascular coagulopathy, this clotting disorder that develops, and that really is an indicator of a dysfunctional immune response. The body's unable to mount an effective response and inhibit viral replication, so you can end up with that cytokine storm to try and suppress it, and that can lead to ARDS and DIC, as the case may be. So if you see signs and symptoms of clotting, you suspect that. Certainly labs is a way to evaluate for that, but sometimes there are some physical manifestations that would suggest something like that as well. DIC in some of these patients, some of these SARS-CoV-2 patients, would be another indicator too of that cytokine storm and that overactive immune response.
Outstanding. Hey, thank you, Dave.
Sure, Dennis. Thanks for having me on.
All right.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.